Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you probably recognize this image here. We have the fallopian tube, ovary, etc. And that's because we're going to be talking about ovary pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, ovary pathology. As we all know, the follicle is the ovary's functional unit. And the granulosa and theca cells surround the oocyte in a follicle. The luteinizing hormone, also known as LH, stimulates the theca cells to produce androgen. The follicle stimulating hormone, or FSH, stimulates granulosa cells to convert androgen to estradiol, which drives the endometrial cycle's proliferative phase. You remember what that looks like? The well-circumscribed circular glands in the endometrium, right? You remember that. A luteinizing hormone spike brought on by estradiol surge causes ovulation, which marks the start of the secretory phase of the endometrial cycle. And histologically, what will that look like? Those winding, sort of bending, flexible regions, right? You remember that. The follicle that remains after convolution develops into a corpus luteum, which predominantly secretes progesterone to stimulate the secretory phase and get the endometrium ready for a potential pregnancy. Particularly in the early stages of pregnancy, bleeding into the corpus luteum can cause a hemorrhagic corpus luteal cyst. Follicular cysts are the outcome of follicle degeneration. Follicular cysts in small numbers are typical in women and have no clinical relevance. So now let's talk about a very common entity, polycystic ovarian syndrome. What is that? Well, the name describes it. Polycystic ovarian syndrome is polycystic ovaries associated with syndromic-like features. PCOS may result from obesity, stress, and hormonal imbalance. The ovaries generate an excessive number of immature or partially mature eggs. This cartoon to the right here does a great job at representing what it looks like. See those fluid-filled sacs or cysts inside the ovaries? That's PCOS. About 5% of women of reproductive age experience polycystic ovarian syndrome. Lab values in polycystic ovarian syndrome will show elevated androgens, elevated luteinizing hormone, and decreased FSH. Hirsutism, right? The little hair, little mustache, little peach fuzz. Hirsutism, or extra hair, in a male distribution is caused by an increased luteinizing hormone inducing excessive androgen production. From where? The theca cells. Then, in the adipose tissue, androgen is transformed into estrone, right? High levels of circulating estrogen actually raise the risk for endometrial cancer, while estrogen feedback decreases follicle stimulating hormone, which results in cystic follicle degeneration. A young woman with obesity, oligomenorrhea, and a little peach fuzz mustache makes a classic presentation for polycystic ovarian syndrome. And some radiologists can actually pick this up utilizing sonography, where they note polycystic ovaries seen on a sonograph. Here we have a transvesical ultrasound that apparently is revealing polycystic ovaries. Future radiologists out there, can you see it? I could see it, so you better be able to see it, because I'm a pathologist. I like colors and stuff. Anyhow, speaking of colors, look at this chart here, showcasing the relevant ovarian tumors that you should be aware of, right? Let's take it back a step. The ovary, as we all know, is composed of 3 cell types. What 3 cell types? These 3 cell types. Surface epithelium, germ cell tumors, and sex cord stroma. And as we know, we can have various malignancies that arise from each, right? We can have serous tumors. We can have surface epithelial stroma tumors. We can have germ cell tumors. We can have mature cystic teratomas with teeth and hair. Tumors can arise from any of these cell types, or even form metastases, start invading local structures, traversing throughout body cavities, becoming so enlarged that a patient may even think that they're pregnant. Yes, very large. Here, we have something very small. It's a histologic section of an ovarian tumor, showcasing an immature teratoma of the ovary. If you look closely, you should be able to see immature bone tissue, right? Do you see that? I'm pretty sure in the bottom left-hand corner you can see some adipose tissue. See some cartilage somewhere. Yes, this is a teratoma. And here we have grossly a representative picture of an ovarian carcinoma. And here we have hair follicles that was likely present within an ovarian tumor that was determined to be a teratoma. And here we have benign mucinous ovarian tumor consisting of a simple non-stratified columnar epithelium. You can see that right there at the top, with basally located hyperchromatic, very blue, nuclei that resemble the gastric foveolar epithelium. And then we have representative sections showcasing immunohistochemistry from a normal ovary, a benign tumor, a clear cell tumor, a serous tumor staining with CCNE1, as well as mucinous and endometrioid. Speaking of which, let's talk a bit about surface epithelial tumors. About 70% of ovarian tumor cases are surface epithelial tumors, which are the most common type. So you must know it. You're going to see it. Surface epithelial tumors, be on the lookout. Speaking of being on the lookout, to the right here we have a micrograph of an ovarian clear cell carcinoma. Surface epithelial tumors are derived from the ovarian coalomic epithelium. The endometrium, endocervix or mucinous cells, and serous cells that make up the fallopian tube's epithelial lining are all produced by the coalomic epithelium embryologically. So it's likely that you will see this in the near future because certain people like to integrate vignettes, wink wink. Now, serous and mucinous surface epithelial tumor subtypes are the 2 most prevalent types. So what are the 2 most prevalent types? Serous and mucinous surface epithelial types, okay? Both serous and mucinous epithelial tumors are usually cystic. Mucinous tumors are, guess what? Filled with mucus, right? Serous tumors are filled with serous watery fluid. Mucinous and serous tumors can both be benign. Well, isn't that lovely? They could also be precancerous. And they can also be malignant. Cystadenomas are benign tumors that are made up of a single cyst with the simple flat lining and most frequently develop in premenopausal women between the ages of 30 and 40 years of age. Contrarily, malignant tumors, i.e. cystadenocarcinomas, are made up of complex cysts with a thick, shaggy lining, most commonly to develop in postmenopausal women between the ages of 60 and 70 years old, right? So a little bit increased age. Tumors that are borderline have characteristics that fall between benign and malignant. Borderline tumors have a better prognosis than tumors that are obviously malignant, but they still have the ability to spread. Interesting. Now, I'm sure you're aware of this mutation, BRCA1. Sure you know about that. BRCA1 mutation carriers actually have an elevated risk for serous carcinoma of the ovary and fallopian tube. And because of the higher risk for breast cancer, they frequently choose to have both a prophylactic salpingo-oophorectomy and a prophylactic mastectomy. Less common subtypes of surface epithelial tumors include things that you must know: endometrioid tumor and Brenner tumor. Endometrioid tumors, which contain glands that resemble endometrial tissue, are typically cancerous. Endometrioid tumors might be caused by endometriosis. An independent endometrial carcinoma, or the endometrioid type, is linked to approximately 15% of endometrioid carcinomas of the ovary. Brenner tumors are typically benign and consist of bladder-like epithelium. Clinically, surface tumors usually appear years later with unusual abdominal symptoms, including discomfort and fullness, or compression symptoms like frequent urination. I gotta go potty. Surface epithelial carcinoma is thought to have the worst prognosis of all female genital tract tumors due to its generally poor prognosis. Localized epithelial cancers often spread, particularly to where? The peritoneum. So be on the lookout for that. The serum marker, CA125, can be used to check for recurrence and track therapy effectiveness, right? So it's not used for screening. CA125 is used to track for recurrence and therapy effectiveness. Ideally, it would be very low or decreasing to low or not even detectable. Now let's switch gears here and discuss germ cell tumors. Germ cell tumors are the second most common kind of ovarian tumor. To the right here, we have a micrograph of a seminoma. Do you see the fried egg-like appearance? Keep that buzzword in mind. And remember, fried eggs, seminoma. Germ cell tumors typically affect females who are fertile. Germ cell tumor subtypes mimic tissues normally produced by germ cells. Fetal tissue is a cystic teratoma and embryocarcinoma oocytes dysgerminoma. Yolk sac endodermal sinus tumor. Placental tissue choriocarcinoma. Now let's take a look at this example here of a yolk sac tumor showing reticular and microcystic areas with buzzword Schiller-Duval bodies. If you hear Schiller-Duval bodies, if you see Schiller-Duval bodies, if you think Schiller-Duval bodies, you should also be thinking yolk sac tumor. Notice in D, we have a malignant mixed germ cell tumor of ovary, which is an unusual combination. And here we have microscopy showcasing a malignant ovarian mixed germ cell tumor. And again. And this is fairly complex beyond your stage, but just take a look at the choriocarcinoma H&E. It looks very dirty, very gritty. The NC ratio is quite large, and the cells are very pleomorphic. Now let's talk about one of your favorite things. Why is it your favorite? It's your favorite because you'll never forget it. You know this. You have dreams of this. You wake up thinking of this. A teratoma. A teratoma is a cystic tumor made of tissue from 2 or 3 embryological layers, including stomach, thyroid, skin, hair, bone, cartilage. Is that a tooth in there? Is that hair? And a particular type of teratoma known as struma ovariae is quite unique in that it is a teratoma composed primarily of thyroid tissue. And here we can actually utilize a CT scan to showcase a teratoma of the ovary. You see that large, well circumscribed, circular, black circle that the arrow is pointing to? That's a teratoma. Notice there's something very bright within it. That's possibly a tooth. And here we have a teratoma that was actually removed from a patient, right? Taken to a lab and cut open so that you can see the inside of it. So that external portion there is the ovary, highly likely, and then you can see within it cystic space. If you look closely in that cystic space, you can see a long, silky strand of golden brown hair. Isn't that lovely? Get some Garnier Fructis and wash that thing on up, right? Now, get your shavers out. Cut some hair. This is a teratoma. And this is a mature cystic teratoma of the ovary, showcasing somoma bodies that are occurring within the papillary structures, right? And again, we see that on lower magnification. And again, we have a teratoma that's been bisected and taken to the lab and made an H&E slide out of it, and it's strictly showcasing these hair follicles that were present within a teratoma. And here we have neural tissue that was present within a teratoma, right? You see the ganglion cells there. We have bone within a teratoma, right? More tissue within a teratoma. Teratoma. More teratoma. And this is what the teratoma looked like grossly. It even has a strand of hair sticking out. And again, microscopically, we can see the cartilage, we can see the adipose tissue, we We can see many different types of tissue within this one slide, as well as in this one. See, I'm hammering home the point that teratomas often contain many different types of tissues. And it should be very, 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 very clear to you at this point, right? Teratomas, all day, every day. Now, this is a particular teratoma that I mentioned earlier. It's primarily composed of thyroid tissue. What do you call it? Struma ovary, right? Right. Now let's switch gears here and talk about dysgerminoma. A dysgerminoma is the most common malignant, keyword malignant. Dysgerminoma is the most common malignant germ cell tumor that is made up of big cells with oocyte-like central nuclei in transparent cytoplasm. To the right here, we can see an ovarian dysgerminoma on gross exam in the top with a tan yellow cut surface and central necrosis, as well as hemorrhage. We have the accompanying H&E below in panel B, showcasing large nests of cells with clear cytoplasm and intervening fibrous septa. There are certain lab values associated with dysgerminomas. You can have a serum lactate dehydrogenase that might be elevated, or serum alpha fetoprotein that is also often elevated. How do you treat dysgerminoma? Well, radiotherapy might do the trick. And the prognosis of dysgerminoma is typically good if radiotherapy treatment is initiated. So you future radiation oncologists out there, remember this. And this is a dysgerminoma, what it looks like in the operating room, surgeons. And this is what it looks like microscopically for you future pathologists out there. Notice the uniform cells that are separated by the fibrous septae and the lymphocytes. And here we can showcase a dysgerminoma that's actually infiltrating the colonic wall. And here we have the dysgerminoma that's characterized by those uniform cells again, resembling somewhat of a primordial germ cell picture that's separated from top left to near bottom right by a long fibrous septa. And also notice the lymphocytes in there, those small, well-circumscribed basophilic cells. Now this is something you'll definitely have to know about, a choriocarcinoma. Trophoblasts and syncytiotrophoblasts make up the malignant tumor known as a choriocarcinoma. Now let me guide your eyes to the right here. This is a very high magnification of a choriocarcinoma. It consists primarily of two important cell types, the cytotrophoblasts that you can see there, and the syncytiotrophoblasts. Choriocarcinoma mimics placental tissue. However, villi cannot be found within them. Choriocarcinoma are described as being small, hemorrhagic tumors that move through the bloodstream quickly. As you can see here to the right, would you describe that as hemorrhagic? Definitely. You see all the red blood cells there? And then you can see the syncytiotrophoblasts and the cytotrophoblasts, right, with their pleomorphism and hyperchromatic nuclei. This is classic for choriocarcinoma. Make sure you are able to recognize these features. A choriocarcinoma is bad news because they have poor responses to chemotherapy. Here we can see an endometrial biopsy showcasing a choriocarcinoma with a decidual reaction. This was actually from a 73-year-old female, right? You can see the inactive endometrial gland there. Would you say that's in the proliferative phase? Well circumscribed circular, right? But take note of the choriocarcinoma. You see how pleomorphic it is? By pleomorphic, difference in the cells, right? You see some large hyperchromatic cells or released nuclei, and then some cells with small nuclei. And take note of the decidual reaction that's taking place in its proximity. And as you know, choriocarcinomas like to spread through the blood and they're very hemorrhagic, right? You could appreciate that here. And this is a representative slide showcasing the choriocarcinoma radiologically, grossly, and histologically. Now, an embryonocarcinoma is a special type of malignant tumor because it's made up of a massive, aggressive primordial cells that metastasize quickly. To the right here, we can see the embryonocarcinoma's histologic features. Now, take note of the nuclear atypia, the prominent nucleoli, and even the necrosis. And here we have various samples of rare gynecologic and breast pathology consultation cases. In particular, in the left panel, we have an embryonocarcinoma also undergoing a CD30 stain, picking up and highlighting that. And these are various images showcasing how NCAD-heron expression occurs in embryonocarcinoma and chorionic carcinoma. Now let's talk about something that you'll likely see though. Sex cord stromal tumors. Sex cord stromal tumors are ovarian tumors that resemble sex cord stromal tissues. A tumor composed of granulosa and theca cells is known as a granulosa theca cell proliferative tumor. Sex cord stromal tumors often release estrogen and exhibit indications of excess estrogen. Precocious puberty may be an indication to check a child for a sex cord stromal tumor. Postmenopause is the most common setting for granulosa theca cell tumors, which may present as endometrial hyperplasia with postmenopausal uterine bleeding. Here we can see a sex cord stromal tumor on high magnification, in particular a Sertoli cell tumor. And here we can see a Leydig cell tumor, which is another type of sex cord stromal tumor. And higher magnification of that Leydig cell tumor. And even higher magnification of the Leydig cell tumor. Know that it's a bit more oncocytic, especially compared to the first tumor that I showed you in the sex cord stromal tumor section. And here we have a low magnification micrograph of a granulosa cell tumor. And here's a high magnification micrograph of a thecoma. And here's low magnification of a thecoma. And this is a histograph showcasing a granulosa cell tumor, which is also a subtype of sex cord stromal tumor. And this is showcasing a magnetic resonance imaging of a uterus, and more importantly, the microscopic findings of endocervical glands in C. And if you look on, you can say the hamartomatous polyp and negative staining on some tumor cells in F of an adenocarcinoma of the cervix. So beware for mimickers. And since we're talking about sex cord stromal tumors, let's go in a little bit of detail about each one of those. I know I went through the histology fast, but that's because we're going to go over it piece by piece. So here we have a Sertoli Leydig cell tumor. And we know that Sertoli cells form tubules in the Sertoli Leydig cell tumor, which also contains the Leydig cells between the tubules and distinctive Ranke crystals. Sertoli Leydig cell tumor may generate androgen, which is linked to both virilization, in which females exhibit traits associated with male hormones, and hirsutism, or excess hair in a male distribution. And here we can see a high magnification micrograph of a what? Sertoli cell tumor. And here we have a Sertoli Leydig cell tumor. And here we have a well-differentiated Sertoli Leydig cell tumor. Particularly in A, the tumor is well circumscribed. In B, it's growing in a somewhat of a tubular pattern. In C, you can see the dark round to oval nuclei and clear cytoplasm on that high power magnification. And D is guiding your eyes to the intervening stroma containing large polygonal cells, reminiscent to the Leydig cells. And this is a Sertoli Leydig cell tumor. Now let's switch gears and talk about fibromas, another commonly tested entity. A fibroma, often called a uterine fibroid, is a benign tumor that frequently develops in the uterus's smooth muscle layer. As you can see here to the right, this is a fibroma of the ovary. Fibromas are a benign fibroblastic tumor. Fibromas are characterized by pleural effusions and ascites, which are features of the Meigs syndrome, a condition that is treated by removing the tumor. Future radiologists, can you see this? How would you describe that? Is it affecting the ovary? Here on CT, we see a very large ovarian cancer as seen on the CT. Can you say that was a fibroma? Well, we can say this is a fibroma, right? Because we have the pathologic specimen right before us. Now, this is important. A Krukenberg tumor. The most common cause of the metastatic mucinous Krukenberg tumor, which affects both ovaries, is something that you must know. It's a metastatic gastric carcinoma, usually the diffuse type. To the right here, we have various pictures of the gross and histologic samples for a Krukenberg tumor. Note that the signet ring cell carcinoma metastasized to the ovary, causing the Krukenberg tumor. Now, mucinous carcinoma, have you heard of that? Mucinous carcinoma is a primary mucinous carcinoma of the ovary. To the right here, we have a ovary that has been sliced open at least. And it looks like all the mucinous components, if there ever were any, are not currently present. But in general, bilaterality helps distinguish metastasis from primary mucinous carcinoma of the ovary. A primary mucinous carcinoma is usually unilateral, by the way. And here we have a mucinous cisadenocarcinoma of the ovary. This is a gross picture of an ovary that had the lesion within it that was sliced in a fashion so that you can see its internal structures. Note all these cystic cavities. There's a bit of hemorrhage, and there's a bit of variance in components. Histologically, we can see this mucinous carcinoma here. This is a micrograph showcasing a mucinous cystadenoma of the ovary, or ovarian mucinous cystadenoma. Note the glandular cells there. Now, what is pseudomyxoma peritonei? Radiologists will see this a lot, and you future radiologists be on the lookout for it. You can notice the massive amounts of mucus in the peritoneum as a symptom of pseudomyxoma peritonei. You can see that on the CT scan here to the right. Appendiceal mucinous tumor that metastasizes to the ovary frequently causes pseudomyxoma peritoneae. And you've completed a very important presentation, not only for test and examination purposes, but for broad knowledge. Because women like to talk and ask questions. They're going to be asking you this, so remember it. Remember all this gynecologic stuff. It comes up over and over and over and over and over. But I have faith in you because you're smart. Keep up the good work. Keep making me proud. If you have any questions, comments, or concerns, reach out, let me know. And I look forward to speaking to you and hearing any of your thoughts, okay? Till next time, take care.